Welcome to Playing with Fire, the podcast for people who are ready to custom build their love.
We're talking about non-monogamy, however you design it, as an individuation opportunity.
Want to leave the default and make your life spectacularly you? You're in the right place.
Hi, Jolie, and today, hi, Ariana. We have a guest today.
We have a guest. We have a guest we love. Somebody we're very excited to talk to.
I'm really happy that you're here.
So, Ariana, my goal today is to have a great conversation, and you have background in so many amazing areas, but we're gonna dive deep into an area that I know you're super passionate about, and something that, as a mother of many, I'm pretty passionate about on a personal level. And talk about like all the stuff we should know about postpartum sexual health and having bodies. Just having bodies.
I love that we're bringing the experiences of women into the forefront. That is so key. I mean, I think I just off the top of my head, having babies is pretty important to our species. Women are important to that process. We could make things better.
It's true. So let me introduce Dr. Cesare. As we get started, Dr. Cesare is a pelvic and obstetric physical therapist. I love, before I go any further, a pelvic and obstetric physical therapist. Why are there not more of you? There should be a lot more of you, but she is par excellence. Ariana has an athletic background in track and field, and I happen to know just finished running, it was a 50 miler, right? Serious.
Yeah, 50 miles.
Serious. Alpine ski racing, dance, marathon, ultra, all the things, Ariana. And a musical background, which is why you have the good microphone. A musical background in singing, songwriting, and piano. The piano's an addition. I did not realize you were also a pianist. Loving this. Dr. Cesare runs a small woman-owned business focusing on pregnancy and postpartum fitness.
Hooray.
Yes.
Hooray.
Getting back to running postpartum, that was hard. That was so hard for me. And sexual and pelvic health, something we don't talk about enough in our culture, in our country, in our society. Ariana creates an inpatient postpartum therapy program for hospitals and is also a proud member of the LGBTQ plus community, advocating for comprehensive sexual and relational education. Ariana, you have been a complete joy every time I have shared space with you. I'm so glad you're here with us. Thanks for joining us.
It's so nice to hear your guys' voices. That just happiness, that little familiarity. It's so nice to see you guys again.
It's great to have you here.
It's so awesome. So I wanted to just dive in and say, so as a mom, so I've birthed 4 times. And when you proposed this topic, like we were talking about, you could talk about so many things. You are brilliant. But when you proposed this topic, what came up for me was this immense grief around what my sex life was and what it could have been if I had received appropriate postpartum medical care. But I didn't. So yuck, ouch, not cool. I want to just start off with like a base question, which is why did you specialize in this? Like, tell us your background story. What made you interested in this?
So I mean, every athlete ends up with an injury at some point. You know, we're no stranger to the PT office. And typically people don't like going to the doctor's offices. But I had to go for a back injury from soccer and was like repeatedly slide tackled knee to the lower back. And it was really not fun. Was like in a wheelchair at high school waiting for MRI results if it was a pelvic fracture or not, just super not fun stuff. And the only part of it that I enjoyed was being at PT. And so I was like, if I really like being here, like maybe I'll shadow. So then I ended up shadowing at that clinic in California. And I joke that I like worked my way up the ladder because then I worked there and then I ended up going to physical therapy school and becoming a physical therapist. And Drew Petula was my physical therapist growing up. He's absolutely wonderful. He treats my mom all the time back at home. And in college, I knew that I had gone back and forth a bit between PT, medical school, and I decided that the the flexibility of PT was more my style, because I get to do so many different subspecialties within PT and pelvic health specifically, like GI, OB, postpartum care, pelvic health. I get to do at the hospital that I work on every floor. So I get to do wound care, ortho, same day surgery, ICU, neurotrauma. Like we're all over the place. The ER is usually a bit of a carnival. I don't know. It's always nuts down there. Everybody's changing rooms.
That's what my nurse daughter says too. She's like, that's where the party is. It's something.
Yeah. If you go in there expecting chaos, then you're like, fine.
Yeah.
But in college, kind of going back and forth, I had decided on PT, and then a really close friend of mine reached out and was like, hey, I experienced a trauma and I'm actually in pelvic health right now. Like, do you know what that is? And I didn't. I'd never heard of it, which is like funny to think of, from where I am now. And so I kind of got to go through that with her and learn about what she was doing. And it was pretty much an immediate shift. And I was like, you sprain your ankle, we can figure it out. But the life-changing, career-changing, like mental health-changing aspect of women's health, I was like, that's it. That's what I'm doing. And I immediately looked for PT programs that had women's health programs, which is how I ended up at Columbia. And thank God I did, because the professor that I did research with was the editor-in-chief of the Women's Health Journal, PT. And just like wonderful experience, wonderful connections. We actually published our research on low back pain in pregnancy. The prevalence is really high, surprise, surprise. And not many people say anything, surprise, surprise. So that's how I got into the field. And then now being in Colorado, that's actually where the first obstetric postpartum program that I heard of was made, and it's down in Salida by Ann Krogan. And so learning from her and other women around me and having the supportive network in Colorado that is more focused on women's health and accepting in a hospital, which is huge to get past all that red tape to have these programs going. And now we have it at 3 hospitals, which is really great. And I'll be going over to another one to do some onboarding they want to bring more therapists on as OB therapists, which is great. So,
well, I want to say thank you. This is work that this is an element of our healthcare that is critical. We need it. It's been missing.
Why? Okay, but why?
Oh,
Here
yes,
it is.
why?
It's 2024. Why is this missing? And how come when I birthed all of my children between 1999 and 2007, nobody mentioned this?
Yeah.
So why? I mean, I want to ask the basic question: why do women need physical therapy during pregnancy and postpartum? But I also want to say, like, do you have an opinion? Do you even maybe know? Maybe there's already been research done. Why don't we do this? Why don't we already take care of this?
I think
you can be edgy.
Yeah. I was like, how do I say this without like commenting on American healthcare as a whole? You can't.
No, please do that.
So, right. So if Ken, let's say that Ken, you went to the hospital, you're a male, you had part of your intestines removed for a small bowel obstruction, and then someone said, okay, time to go home. We're not going to talk to you about any recovery information. Here's a puppy. Good luck. Do you think that would go well?
Here's a puppy.
Do you think that would go well?
No. And I wouldn't expect it, because I would expect a flock of doctors around me telling me all the things that I need and should have and are entitled to. Because...
So that's exactly what we do with our cesarean patients.
Oh.
You get a massive abdominal surgery. It goes through 7 layers of tissue. It removes an organ, the placenta. It removes a living object, your puppy, right? Your new baby. And then you are patched up, ignored, and then sent home.
Wow.
Best of luck to everyone. And it's not a ton better if we vaginally deliver, because I had 88 stitches the first time I vaginally delivered. And nobody mentioned a word. Nobody did anything about it. And I did have, it was a cute puppy, but seriously.
It was a cute puppy.
It's not awesome.
Yeah.
And this just hasn't, my experience has been that we just haven't talked about it. So as a cisgender woman myself, no one I was raised with, none of my doctors talked about it. And it wasn't even a part of my the conversation about my general health at any
Mhm.
level. When
And I'm
did
so
this start
sorry
shifting?
about that.
Yeah, I mean, it's
It's
a
just
bummer.
the
But
grief piece as well, and other cultures do this better than we do, but one thing that I like to bring up, whether it's a delivery or a miscarriage, or, another form of miscarriage, I always bring up that there is a grief part of it, right? So
yeah,
grieving not only the loss of like the sex life that you mentioned, that's different. It looks different, especially recovering from, a traumatic obstetric injury, 88 stitches. It doesn't sound like that would just easily bounce back. That scar tissue doesn't stretch the same way. That scar tissue doesn't move the same way. So a lot of times returning to intercourse or even having bowel movements after that amount of stitches is really difficult and really painful. But also the grief of your lifestyle, your personhood, your individuality, that you now have someone completely dependent on you, and the grief to not maybe lose, but to change so much at once, and to feel that you lose a part of yourself in that. Even if you find something new along the way, it's that like um intermediary time between settling in to your new family
yeah,
and being pregnant and having, you're able to walk around and do everything by yourself. So it's just that grief period that's often overlooked. And so I like to bring the attention to that, like, you might be really sad when everyone around you is extremely happy with their brand new baby. And this is outside of postpartum depression. This
yeah,
is like a personal grief. Postpartum
right.
depression is another entire thing. And I give everybody the Edinburgh Depression Scale after assessment to, double check on them and get case management involved. But yeah, it's a huge change, and some people don't deal very well with huge change,
Yeah.
and it's really
Hmm.
tough, and it's often missed.
And it impacts our family system that may have just formed if this was a first infant,
Mhm.
and it's impacting then the trajectory of our children's lives as well as ours. So I appreciate that you're bringing in grief. One of the things that I hear people talk about is like, when did you go back to having sex? When, and like rushing into questions of like, when did you do the next thing?
Realistically, or when you're clinically allowed, because it's
Like,
about 2 months of nothing going in there, and
right.
then I've had somebody, at work that's like a year postpartum and is terrified. There's no physical limitation necessarily, but terrified to get back into intercourse. And that is where I come in with like the physical rehabilitation, the neurodesensitization, and all of those kinds of like physical adaptations to this new body, and being comfortable in it and being comfortable with touch. Some people don't want to look at themselves after. I've had people that will not touch themselves after, or their cesarean scar, whether that it hurts or that it's traumatic. They, some people won't do the scar massage, and I do it for them.
Yeah.
um, it's really a really big deal, the mental side.
Yeah,
Yeah.
it's a huge deal. And I just want to say we're talking about the bodies of cisgender women here. But I think it's worth mentioning, and you have been wonderful about talking about this. Like, cisgender women are not the only humans giving birth. And
Right.
so
Right.
like
Yeah.
let's just open up the conversation for a moment and say like all of this intensity that you're talking about. Now I'm thinking about a trans man who
Hmm.
who chooses to go through
Carries for their
pregnancy,
partner. Yep.
carries for their like there's so many reasons why you might.
Yeah, trans men, non-binary folk,
Yeah.
and just also like the terminology around everything on the labor and delivery floor is mom baby. If you don't identify as mom, if you are dad and you are delivering, if you are them and you are delivering, if you have, a unique parent name that you don't feel that mom or dad fits you, all of the paperwork, all of the like conversation, it's all around mom. And I feel like that's really isolating.
Right.
In my research paper and in presentations that I give, I try to remove the word woman as most as I can, because it doesn't apply all the time, or the WOMXN, like.
Yeah. And I wanted to mention it because I was thinking about how all I think the three of us were holding the tension of how painful this can all be and how much it can impact life. And then we add the complexity of, yeah, and what if you don't fit into the
Right.
mold as
Now we have a
Mhm.
well? What
whole
if
other
Yeah.
level
Yeah.
of chaos
right? And I was
in the
thinking about the
experience.
dysphoria.
Yeah.
you were mentioning like, well, what if scar tissue massage is going to be triggering to you? There are lots of reasons why that might be.
Mhm.
And it made me think about what it is to be in a body that maybe doesn't feel the way you want it to feel for a million reasons. And
Yeah.
to just be in the question, I just want to make sure that we're taking account of how broad and what a
Yeah.
huge swath of our population will be touched by this, because then I want to talk about more about the bodies that are birthing, but also then we have the partners of the people who are birthing and their
Yeah.
confusion, their massive
Yep.
confusion, and their lack of education. Ken, I'm imagining you, like, I'm trying to remember back then whether you even could say all the words.
Well, this is what I've been thinking about. It's like, okay, so what was my experience of this person who is pregnant and dealing with the pregnancy? And I remember being very supportive from the practical, like I could see what was happening practically in her life, in the house, day to day, because I was right there. But the psychological things that were going on, and the um it was so practical, and it's such a very important, but not at all the whole story about what's changing.
Yeah.
The grief of what's coming is so important, particularly like okay, this is the first child. And I remember the occasional conversation about, hey, so after you have a child, everything will change. And then the conversation just kind of stopped. It was like, well, do all the things that you want to do before you have a child now, because then you'll have a child. And that was it. There was no like, oh, by the way, you are going to have things to grieve, no matter how happy and joyous you are about having a child, your life just changed.
Yeah.
In
Also,
an
as if your personality dissolves once you deliver, like
well, yeah, right.
Yeah, because Ariana,
Yeah.
you're never going to want to like run ever again, right? Like that. Why would you do
I'd
that? Like what?
probably never sing a note.
So
Yeah.
Right?
right?
Yeah.
No,
No,
so
it's going to be
strange.
all. Yeah. So there are so many conversations that just aren't had. And when you were talking about just about the forms and the language around this person who's delivering, um, there are things that we can do about that in the, like, so maybe there you are in a hospital, and maybe you
Yeah.
have some influence and you're able to make some
I
changes.
have a form that I made of gender inclusive language that has the traditional terms and then an empty column for patients to fill out what terms they wish that
Oh,
item to be referred to, whether that's a body part, a name, and then also
Yay.
just like the inclusivity of different types of families in the room. Like
Yeah.
you walk in and there's two women, that's, it might not be her friend, that's
Right. It
the
might not
other
be her
mom.
roommate. That's
Yeah.
yeah.
Oh,
right.
I had a funny experience the other day. I walked in and I was like, "Oh, are you, this name?" And the woman is holding the baby and she goes, "Yes." And then the woman in the bed goes, "What? That's me." And she was like, "Oh, I'm sorry." And she was like so flustered that she'd answered as her wife's name. It
Mm-hmm.
was so
Mm-hmm.
cute. But I always ask because like I'm not going to assume who you are. Like you could be a sister, you could be a wife, you could be a friend, you could be, her
And
mom who looks the same age. I don't
and
know.
poly families are showing up to delivery
And
rooms.
having
Polyamorous
the
families.
multiplicity in the room, right? Like
Right.
Yeah.
so who signs the paperwork, right? Is it if it's like a level partnership where like everybody is equal, or if it's hierarchical, right? Then like does the
Like
primary partner sign the paperwork? Are they the medical POA? Is it split amongst the other people? Legally, I'm not quite exactly sure how that works,
right. And it
but
depends on where you
Neither
live.
is the legal
The
system
legal
for
yeah.
the
system
most
isn't
part.
completely
Yeah,
clear
Yeah.
that's
either.
true.
Yeah.
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 But at least for like the social side of it and the human side of it and being kind and like asking people how they want to be addressed, who do I have in the room with us, and making sure that you let the patient tell you who is in the room with them, because
Mm,
they'll name people the way they want to name them, and that is
yeah.
how I will call them. Whatever you want, I will do.
Right. Because we're talking about a social relationship. When we're talking about labor and delivery, when we're talking about your postpartum care, we
Mm-hmm.
want to be we want it to be care. And
Yeah.
I would love to just like pivot a little bit into what you recommend. Like what can we be doing differently to handle this? I mean, there's so much. We could talk for hours about
Yeah.
all the things that could happen in within pregnancy to help the pregnant body experience the best health it can, and including having a sex life while
Mhm.
you're pregnant. But we can also talk about postpartum. So I'm really open here. I'm curious. How do you like to discuss this? Like, do we start with pregnancy or do we start with postpartum and work our way back? What do you prefer?
I usually start with pregnancy because my professional recommendation is to be getting prenatal care from
Mm.
a physical therapist or occupational therapist throughout your pregnancy. Not everybody's going to need like every single week something super intense, but at least to check in. Every trimester to check in, see how things are going. If something starts to bother you, then to address it, and you don't have to wait until you've delivered. Because, Ken, if you had a backache and it was acute and we knew it would go away in 9 months, would you just sit there for 9 months? No.
Right.
You'd
I
march on over to the physical therapy place and get some treatment,
but
because
I don't
why
wanna have
suffer
a
for 9 months when you can
backache for
improve
9
it?
months, yeah.
Exactly. Yeah.
So what are
Um,
the kinds of things that, what are some of the common things that come up that like, okay, this is we're during pregnancy, we're nowhere near the actual delivery. What are some of the things that come up that people are like, maybe this could be better?
so the most common things are like incontinence, back pain, pelvic pain, painful sex, pubic symphysis dysfunction, so that's the joint at the front of the pelvis that typically doesn't move very much, but with ligament laxity starts to get hypermobile, and that extra mobility all of a sudden in a joint that doesn't move very much can be really painful. Sciatica, rib pain. So some people get really confused when they have like under breast rib pain, but it's because the baby is pushing your rib cage up and out. And when it pushes up and out, it can pinch where the nerves come out in the back, and that can radiate around underneath the breast. So
I'm 5
surprise
feet
rib
tall
pain.
and had 10-pound babies, so yes.
Yeah. And
Yeah.
then postpartum, getting the ribs to come back down. Sometimes they get stuck up there. The muscles contract and they get tight in that elevated position. So even working on breathing postpartum and bringing your rib cage back down is something to look at.
So
Mm.
I'm moved to say at this point that, so to the people listening to this, if you are pregnant or know someone who is and they are experiencing something they don't want to experience, there may be something to do about it. It might not just be, and this, I say this because this is what I remember from my partner's pregnancies. Oh, you just deal with it. You just, this is just pregnancy. And so you just have it. No, there may be things to do about it. So think about
If you're
that.
just listening to the audio, I just look like I saw a ghost
Yeah.
because, um,
Yeah.
yeah, the number one thing that will get me up on a soapbox is telling people to just deal with it, or that it's just normal. There are plenty of things that are super, super common, but that doesn't make it normal, right? Millions
Mm.
of people in the US have diabetes. Doesn't make diabetes normal. Millions
Right.
of pregnant women have pain during pregnancy. That doesn't make it normal. We still want to treat it. It's still pain. It's still a musculoskeletal orthopedic thing that's going on. It's not a mystery. It's not like magic in the wind and it'll just go away, because oftentimes the things that come up during pregnancy, if they're not addressed, become chronic problems postpartum. Just
Yeah.
because you have back pain that starts during pregnancy doesn't mean it's going to disappear postpartum. Your body has gone through so many changes, and sometimes that nerve hypersensitivity doesn't go down on its own. Even though the posture changes and the position goes back and the organs go back in their place, or back in your body if they were taken out during a cesarean, they put them in a little dish next to you. You're inside out for a
They
little
don't go
bit and
too
they put them
far,
back.
but there they
Yeah,
are
they're right next to you.
outside.
It's a
Yeah.
clean
Inside out.
dish. It's okay.
Yeah, they're
Yeah.
working from home. They're right there. But
Okay, great.
I'm trying to
Home.
think of what else. Oh, like body mechanics. How to move
Mm.
with a big belly, how to pick stuff up
Mhm.
without hurting your back, how to get things in and out of the crib, baby or toys in and out of the crib, how to do bath time without hurting yourself. These are all things that I like to go over and educate on prenatally, so that you're not trying to do it for the first time correctly with a brand new baby for the first bath time ever. If you've done that motion, if you've practiced it, if you are familiar with lifting mechanics, it's going to be the way that you do it normally when the baby comes. And that's so much easier than trying to learn how to parent and how to lift and how to move and how to do all these other things.
And how to figure out how to have the relationship you had that isn't what
Oh,
it
yeah.
used to be because the whole world just changed. Yeah.
Yeah.
That's I love that. Thank you again. And again, um, my experience of being a brand new father and pregnancy is like 20 years old basically now, but because we don't have the conversations, I don't think a lot has changed in the common like perception of how things should go, including, and I loved what you said about that, post pregnancy, things might not go back to the way they were.
So,
And I remember being assured, no, everything is fine. This is just pregnancy. And then it will be over and you'll be right back where you were.
which is also how we act about our sex lives.
Right.
Yeah.
Like,
Yeah.
some people I love sex during pregnancy, like love, 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 love it. Not everybody does, but whatever your experience of it is, we don't know what'll happen postpartum. We just don't know, both
Yeah.
psychologically and physically.
Yeah.
And yet a lot of people feel very rushed to return to sex. I'm curious. So we talked about some of the things that should be addressed during pregnancy. And I love the idea of that proactive care, that prenatal care.
Yeah.
And then what about, well, actually, then there must be delivery.
Yes,
That's an ultra marathon, at least the way I do it. It's an ultra marathon. I don't like to do it for a short amount of time. I like to go for as long as possible.
Enjoy the experience.
Yeah, I really like to
savor it.
savor labor.
Sure.
Really, really do. Yeah.
So I actually
there must be prep.
Yes, I have a client who is due in August, and our next appointment is doing delivery prep. And then one last thing on the biomechanics, I always teach the partners as well, especially how to pick up the car seat. And I get sometimes a funny reaction from husbands, and I'll say husbands exclusively because the wives that have been there have never had this facial expression, but they look like deer in the headlights, like, why do I need to pick up the car seat? And I'm like,
no.
aren't you gonna parent the child?
You're having a baby, right?
Yeah, I'm like, are you ever gonna carry your son? And they're like, I guess so. And then they'll get up off their phone, and I try to, get them to pay attention at the beginning of the appointment. But they'll come over and then teach them how, because they're, the delivering person isn't the only person that's going to be carrying the child, carrying the car seat, lifting stuff. So I always teach the partners as well. And then in delivery prep, I also have the partners come in if it's in person or virtually and do more like remote education. But I'll have them do peridial massage, so massaging the outside of the pelvic floor, and then also teach them how to do an internal stretch, so stretching the introitus, and that's just the opening of the vagina, like that skin that's right around the opening, and then stretching the pelvic floor muscles as well, because we don't want to have, we want to decrease the risk of tearing if we can. And so learning how to relax, learning what it feels like for those muscles and skin to stretch, and then also working on pushing mechanics. So everybody's seen in the movies where somebody is like in a like recliner chair position, gripping, like breaking their husband's hand, their face is turning blue, and like they're pushing as hard as they can.
In the worst position they could be in.
Yeah. So when you push that hard and hold your breath, you are putting so much pressure down on the pelvic floor, and you are trying to activate so many muscles that the pelvic floor will actually contract, because you're then globally contracting, and you're closing the door on baby's head.
Yeah.
So,
I did that for 4 hours with baby number one. Yeah, for 4 hours. And nobody was walking me through it. Nobody. And I had done a bunch of prep, but then once you're in the delivery room, well, I was also 23, didn't know anything, all went out my head. But it's that image of like, oh, but you're closing the door because you're globally contracted.
Yeah.
And I want to, like, I'm going to just zoom out to a psychological level for a second. I was also psychologically contracted. I was having panic.
So stressful.
And I was stressed. And now I was in a position that I already knew was not the right position for me to birth in. And all of that amounted to an unnecessarily difficult delivery.
Yeah.
It didn't have to be that difficult. And I know this because then I had more deliveries and they were not like that.
Yeah.
That's such a good metaphor to just remember, like, this is the prep work could help you understand what's going on down there. Like nobody
Yeah.
prepared me for the sensations that I was
Mhm.
going to feel as my body needed to open that door.
And it's tough too with like epidurals where you don't have that sensation. So
Right.
that's where the prep work comes in really handy so that you know how to do it. Like you know how to do the motion, even
Without
if
the
you can't
feedback.
feel your lower half of
Mhm.
your body, because you can also put your hand like over the vulva, just over the outside of the opening of the vagina, and you can feel are those muscles lengthening and pushing down into my hand, or are they pulling away from me and squeezing to contract? So
Yeah.
even if you have an epidural, you can feel that with your hand. Your hand's not numb. And then that's part of the prep work too, is because I would never go and sign up for a 50-mile race and like wing it day of.
Right.
I would run beforehand, like I would practice.
Yeah.
Same
Yeah.
thing with the pushing mechanics and same with the lifting mechanics we were talking about earlier. I don't want your first time trying to do a movement to be on performance day. That's
Mhm.
not a great idea for any sport, for really any activity.
Yeah. I so appreciate the idea of just of prep, delivery prep from a PT perspective because I did a lot of birthing classes, but they were much more along the lines of like preparing yourself emotionally to be present for the
The
birthing,
baby.
the baby, and also for
Everything's
like
for the baby.
yeah, and then like even when I took Bradley, I took hypnobirth, like I took a lot of those classes where they prepared me mentally but we still didn't get into, like, really, like, deep down, like, "Oh, but this is what it's gonna feel like when you're pushing." And once I finally it took me 3 tries to learn how to push effectively, like, 3 whole pregnancies. And once I did it on that 3rd pregnancy, and I was like, "Oh," I actually looked at my midwife, and I birthed at home
Mhm.
for the last 3. I looked at my midwife, and I was like, "That was what pushing was supposed to be like?" She's like, "Yeah."
Yeah.
Yeah, sorry, you didn't get the body wisdom, and what for me, I'm hearing you say is there are lots of ways to explain how this might feel in your body. There are lots of ways to prep you, but if people aren't comfortable talking about it and, like,
Yeah.
giving you ways to
Yeah.
get the information, then you
Mhm.
just get, like, a sentence or 2, and if that doesn't
Yeah.
land I think people did try to educate me, but they didn't get it across in a sentence or 2, and then that ship sailed, and I was
Yeah.
left on game day
And the
going like,
physical
"What?"
practice is really, yeah, the game changer.
Yeah,
And then positioning as well, like practicing pushing on your side, practicing pushing on all fours, practicing pushing on your back if you do end up in that dorsal lithotomy position. And then also like with an epidural, you can move. You can be on your side with an epidural. If your legs aren't 100% numb, you could be on all fours. And I've seen all of these in person, with an epidural. It is possible. You're not immobilized.
yeah.
And then, an active labor is also great too, like moving around the room. We've got the peanut ball, the yoga ball, all those kinds of like rhythmic rocking, like pelvic opening and relaxation techniques. So there's tons of stuff that you can practice ahead of time so that, again, in the delivery room, that's not your first rodeo.
And so you have options because we don't
Hmm.
know what's gonna happen. I
Yeah,
mean,
you'd be
we
like,
can
you know
have our
what? This
plan,
doesn't feel good. I'm going to roll. Like,
but
Yeah.
we having options, and as the non-birthing parent or parents, it's nice to have options to offer,
mhm.
like, to pregame that, like, "Oh, what are the things that I could be there supporting?" I was a doula for a long time, and that was like, my number 1 skill was just that I could memorize a lot of things that we could do, so I had,
I
like,
love doulas. I
I had
love
lots of
doulas.
options, and yeah, and, like, the non-birthing parent, generally speaking, had, like, one idea, and they just didn't know what to do. So
Hmm.
I appreciate the idea of like the preparation for a whole unit, a whole birthing unit, like
I
everybody
love that,
involved.
and so the birthing parent's busy. And as we talked about in the green room before we started this, it's really easy to forget everything you know in the moment of stress. So it's like, okay, I've been studying all of this and I'm ready to go. I mean, we were talking about the podcast. Like, yeah, I know all this stuff, and now the camera's on and it's all gone.
Yeah, that's
And
like when
that's
someone's like, "Oh, what's your favorite karaoke song to sing?" I'm like, "I've actually never heard a single song in my
I don't know
life."
the
not a
song.
one. What's music again?
Yeah.
Yeah.
Is there a
So
beat?
exactly. And so having people around who have spent some time um, themselves learning all the options and all these different things, as a non-birthing parent, I, like you said, I knew a couple of things and I wasn't under the stress, so I was able to offer them in the
And
moment.
I was lucky enough to get to be with Ken while his twins were being born. I did not birth his twins, but I was there, and I was glad you had a couple of ideas. And I was the doula, and I was glad I was there
That's
too.
awesome.
Yeah.
but because it really does take a team. So that something that
does.
I don't know that we've talked about is you must work as part of ideally a care team. And I know that you've built programs so that
Mhm.
that's available, and that's not available for everyone. So
No.
before we go any further, I would, even though this might feel out of order, some people are going to have access to awesome care in their hospital of choice, in their birthing center of choice, but not everybody is. Do you offer opportunities for people to learn this stuff on their own if they don't have access? Because not everybody does.
Yeah, so I've worked outpatient pelvic, and then I've also done inpatient now, and doing things through insurance is great, but, like, I get cut off at some point whether or not they're better because,
Mhm.
somebody who's sitting in a basement with no medical training gets to call the shots on how many sessions they have. Um, and so what I have found is a really good balance is that I do virtual education, and it's not through insurance, but because it's virtual and it's not through insurance, it's a lot lower cost. And that way you don't have to pack up baby, you don't have to find a babysitter, you don't have to leave your house or add a commute. Also, because it's such a sensitive topic to talk about, it's nice that somebody could just like be in their bedroom on the phone with me, or on Zoom, and have a comfortable like education session at home. So yes, I do.
I love that
That's
because
great.
I did get some wonderful care that was, and this is like 25 years ago now, but like over the phone postpartum care was incredibly effective and helpful for me. So if you're like thinking to yourself, like, but yeah, but my situation doesn't, there's nobody around me. We weren't even talking about distance care at that point,
Hmm.
and it was really, really effective. And I would encourage anyone to reach out to you and just be aware that like that kind of education is within reach for many
It
of us.
exists.
It
I
exists.
exist. What you're dealing with is real, and we are here to help.
Yeah.
I also do like just texting access too, and I feel like
Mm.
people really like that because if there's like an anxious thought or like something that comes up in the middle of the night, and just like shoot a text over, I read it
Yeah.
when I wake up, and then we deal with it, or answer during the day, and
I
it's
love
just like
that.
a nice like easy point of contact for like just little questions that maybe don't need a whole like 30-minute conversation.
I absolutely love that. You know, I'm a big fan of,
We text, yeah.
yeah, just like actual conversations with your providers and with your care team. So, Ariana, can we talk about painful sex?
Hmm. Hmm.
Painful sex. And we've been focusing on postpartum, and I feel like we could broaden the conversation here, because painful sex could happen because of pregnancy or postpartum, but also for any number of reasons. Now, if you think that we should sort those situations out, more than happy to, but I just want to talk about painful sex and what a pelvic PT might be able to
Yeah.
help us with.
I love not siphoning off obstetrics into the nether. So let's keep it all together.
Yeah. Yeah. Great. So tell me where do we start? What does it even mean actually to you when somebody says painful sex? Like as a PT, what alarm bells are going off for you, or what questions might you ask?
So the first question is like, where's the pain? Because some people are like, I have really bad back pain with sex, or I have really bad ankle pain, like I can't do this position and it hurts or whatever. And it's sometimes, most often, it's pelvic pain. But just to kind of at first get the whole picture, like where are you hurting? Does it hurt your wrist to hold in a certain position, or does your shoulder dislocate or something like that? And so first, kind of figuring out where the problem is, and if the problem is a pelvic problem. Oftentimes, it's either a nerve hypersensitivity or a muscle hypertonicity issue. So, a tightness or a chronic pain, heightened sense of pain issue. And that could be like vaginismus, which is just an idiopathic muscle tightness. And that, I mean, say idiopathic, but like what I see the most is that and this is stigmatized. So, I want to remove that from when I say the words psychosomatic, because the somatic part is legitimate and the
It's
psychic
real.
part is legitimate. And when someone is nervous and their heart races, we don't give them a psych consult, right?
Right.
Like that's a
Psychosomatic does not
psychosomatic.
mean you're psycho Let's just like be real colloquial here.
Yeah.
Psychosomatic is a way of describing how this is mind body pain.
Yep.
Like
Yep.
this is connected because
Exactly.
you're a mind and a body all together.
Yep.
That's
and so,
all. Yeah.
You know when someone's really stressed and they raise their shoulders up towards their ears and you're like, hey man, I can see visibly that you're really stressed. Why don't you chill out and put your shoulders down? And they're like, oh my gosh, yeah. I didn't realize I was like tightening up like that. So evolutionarily speaking, the neck and the reproductive areas are very protected parts of the body. And so when you are stressed, your body starts to protect those parts, whether that be your shoulders creeping up or the pelvic floor tightening. Nobody can see the pelvic floor tightening. So no one's going to go, hey, Ken, it looks like you've been squeezing your pelvic floor for 6 hours. Why don't you relax? And so that is like a really sneaky mechanism for hypertonicity to develop, because if someone is chronically stressed or chronically you're dealing with PTSD, whatever kind of trauma that's from, and that is their stress response in their body, nobody's going to notice it unless you go get like a well woman exam and your physician knows enough to then send you to a pelvic PT.
And they're
or
really
OT.
thorough.
Right.
And on top of all of that, and if they even care. Because not everybody cares.
But also just as like a PSA, those vaginal exams at the gynecologist are not supposed to hurt. They are not supposed to be painful. Speculum exams are not supposed to be painful. IUD exams should have anesthesia. Like, if you go in for a speculum exam and you know you have pelvic pain, you could ask for the smaller speculum size. You can ask for lubricant, for it to be warmed up, for them to go really slow, and just advocate for yourself, which is terrifying, I understand, and difficult to stand up to a medical professional, but they are there to work for you, on you, with you. So if that is something that you've experienced, just know that that's not normal and that should go better, and it can go better.
Yeah, I appreciate that add in, because the number of times that I have listened to a person talk about the pain that they experience from their caregiver, from the person, their provider is actually causing them pain because they don't know that they're allowed to even name their pain.
Yeah.
So like use your voice, and you may need an advocate with you.
Mm-hmm. Bring a friend. You can bring
a friend.
somebody to those appointments. Yeah.
Yep. I brought my mom to some early ones. I absolutely did. Yeah.
I really appreciate your point of view that you've said a few times, Ariana, that just because something is common doesn't mean it's normal. Just because this is an experience that lots and lots of people have talked about and have, it doesn't mean it has to be that way.
Yeah.
I love that. And so to our listeners, consider that the experience you have that you're not liking, you don't have to just put up with it.
If your body doesn't like something, it's probably because it's not going right.
Right.
Yeah.
Also, tampons are not supposed to be painful.
Right. So this brings us to a really interesting part, like, of the conversation. Like when you said, let's basically do a body scan. Tell me where is that pain? Because I hear people talk about painful sex, and sometimes they're coming to me as a sexuality educator, and they're talking about the pain of their psyche, their soul. Like they don't even mean physical pain. But when we're talking about physical embodied pain in the pelvis region, there's so much that could be going on. But can we just talk about insertive pain? Like the pain of, like you said, so many things that we might want to put into a vaginal area and then cause pain. I mean, we could go a million ways with this, but what should people be aware of?
There's like different diagnosis codes too for like superficial and deep dyspareunia. Usually if it's pain right at the beginning of insertion, that's more of like that first layer of the pelvic floor muscles being hyperprotective, being tight and trying to block stuff from coming in to protect you. It's maladaptive, but that's what those muscles are trying to do. And so for that, we would work on down regulation, a lot of meditation, a lot of yoga stretches, physical stretching of those muscles. And then I don't know if you've heard of dilators, dilator therapy. Yeah. So they look like dildos, but they're in an increasing size from something that's like the size of my pinky up to whatever the size of your partner or other object that you're using to insert is, and medical grade. And so that silicone like variety of sizes that you can use helps to then progressively stretch those muscles to the point where you can tolerate whatever else you're wanting to insert and remove.
Yeah.
And so dilators are really helpful. If it's the deeper penetration, sometimes that is just that people aren't spending enough time on foreplay. I give people a hard
Not getting
minimum
enough
of 20
vaginal
minutes.
tenting. We
Right.
need
Yeah,
vaginal
those muscles
tenting.
to elongate, for the like self lubrication to start, and then just keep lube on hand. Always use lube. Literally always use it. It is your best friend. The brand that I use at work is Slippery Stuff, and it is super great. No one's ever had a skin reaction to it, so that one's usually a safe bet for me to recommend. But yeah, at least 20 minutes of foreplay and lubrication to let those vaginal muscles relax, let the pelvic floor relax and elongate, because if you're immediately going and straight up just hitting the cervix, that cervix is attached to connective tissue, the peritoneum, that goes through your entire abdomen. And it is possible that if you hit it hard enough, it can radiate pain through the abdomen and cause you to throw up. So people do have like
Which isn't
serious...
sexy.
No, it's actually anticlimactic. Yeah.
Yeah.
Yep.
I love this. Okay, the conversation here about like tampons shouldn't hurt. Speculum shouldn't hurt. Like I always have them use the smallest size speculum because I happen to be small. I had 4 babies. You wouldn't think that would be the case, but here we are. There
But
are
then that's
adaptations.
I wanna respond to that, because the idea that pregnancy modifies the characteristics of the vagina, is that true?
No, I mean, it
Right.
might modify it by now having stitches, but
Right, but
your general anatomy and
your
size,
anatomy
like...
stays the
Like
same.
it was
Yeah.
it was designed to
Yeah.
stretch and go back.
And then
Yeah.
go back.
It's
Yeah.
So I
designed.
just I wanted to call that out, that
Thank
like
Yeah.
you.
the story is that changes. That's not what happens.
But when you talked about the different ways we might work with the body, I love the idea of dilators because they're not actually just about whether the tissue stretches. They're also about you learning to insert something in a way that feels safe and feels
Mhm.
good enough to your body to want to do. And from my perspective, when I've used dilators and when I have worked with people with them who are on a protocol to use them, it's as much about their psychology as their physiology.
Yeah.
This is really an opportunity to relearn what it means to insert. Like,
A
what is
huge
that?
A huge part of the dilator use with like trauma patients, like post-sexual trauma, is the fact that they are controlling the object. So even if their partner was using something the same size, like their finger, something very small, you are not in control of their finger. No matter how close you are, no matter how much trust you have, your body knows that it is not in control of those motions. And so practicing tolerating that motion on yourself that you are controlling, that you know how far it's going to go and you know when it's going to stop, is a huge step forward in the trauma recovery work of being able to tolerate any kind of penetration and feeling that you have a sense of control over it.
Right. So that's enormous. And there are lots of reasons why someone might have the conditions that we've called vaginismus and dyspareunia.
Mm-hmm.
Like I'm less concerned about the origin story of it and more concerned with, do we understand that there's lots of stuff we can do? But you also mentioned depth, and that made me think of the O-nut.
Yeah, I was going to ask if you
Oh
knew
yeah.
about the
I
O-nut.
do know
Yeah.
Those
about the
things are great.
O-nut. When you
They're
got a
like
big partner, you
little
want to know.
they're like little jelly bumpers that you can stack to prevent your partner or like sex toy from going in a certain depth. So you can stack them up as far as you need to be what you can tolerate. Because if it's just like anatomical size differences, no matter how much foreplay you have, it's still too deep, then the O-nut comes in handy as well. It's like, and it also takes a little bit of pressure off of the penetrating partner to be not so on edge that they're going to go too far. And so it's a big stress relief.
Right. I love that. When I first saw the O-nut, I think I was at an ASECT conference and somebody was demonstrating and I was like, where has this been my
Yeah.
whole life? Because
It's a good
it's
idea.
solving, right. It's solving a
Yeah.
problem that ideally would be just easily solvable. And then boom, you just have a tool. So it's just soft and squishy. The penis owner can just wear that and like, boom, now you have a solution to relax everyone when you're trying to achieve a moment of joy.
Yeah. And sometimes too, it's like
Relaxing.
positional, right? Like some positions, the person
Right.
is able to hit a different angle that, depending on how your uterus is angled, might be uncomfortable. So then working on like just going through different positions and like what you're able to hold. And then you kind of get into like a fun, like exercise focused, like a sex focused exercise routine where it's like, okay, I can't hold this position. I want to work on my endurance or my arm strength. And then we're like doing bench press so that you can hold a plank and do like a
Right.
certain position. And so it's like
I've
such
definitely
a
done that.
fun cross
Yeah.
from bench press while, it's such a
Yeah.
fun like cross of like PT and sexual health, and then kind of doing that whole picture look at things. Or like I had someone that was, oh, this was back in New York, and they couldn't maintain being on top because their hip, like external rotation wasn't enough. So we were working like on hip mobility, but for that reason, right? So
Yeah.
you're at the gym, and even if you're at your home gym, like you look like you're doing hip mobility stuff. Nobody's going to know that it's like for positional, recreation.
Unless you're me and you share
Or
with the
you tell, yeah,
class,
yeah.
because I will just say anything. I really will. But
This is why I'm doing this. I wanted to so you brought up the idea of you might desire or require certain positions during sex. How how can people effectively ask their partners for things like that? I mean, that's so there you are. And I know my experience and experience of other people that I've talked to is that yeah, stuff's just supposed to work. Not supposed to have to ask for stuff.
Yeah, I feel like having something to bring up is also helpful. So like Googling like, "Oh, I need help with this. Like, I can't do this position." And you kind of Google, and then you like, maybe you've come up with like a wedge or something like that. And you're like, "Oh, I need to show this to my partner," because it's like, "Hey, do you want to try this?" It's not just like um a blank like, this isn't working, because that could start an argument when it's meant to start a conversation. But if you have like some sort of actionable thing, it's like, hey, do you want to try this? I think it'd make it better. That's a nice way to start. Also, just direct. Just write it out on your phone. If you're nervous, read it straight off your phone to your partner. I want to try this. I looked it up. This is what I think, would be fun. And just having it written down, reading it in your head a couple times before you say it out loud to them, but just a little bit of like a little backup. You have it written down. You're like, I mean it. I wrote it. I want to try this.
yeah, it's so challenging to bring these topics up, and that is one of the hardest parts of being a sex educator is uh, we could address 90% of the problems if we all felt comfortable talking about them with our partners, with our friends, with our practitioners. But it's hard. It can be incredibly challenging. We may be dealing with cultural issues that block us from feeling like we can talk about it, or it may feel like it's oh my gosh, if you were raised in purity culture, or it may just be that you never even learned the language, so you're not even exactly sure. So I love the tip of like, write it down. I always tell people like, practice saying it out loud ahead
Mm-hmm.
of time, because ideally we would all be talking about our sex lives in the ways that we want to, and it would feel comfortable. But most people struggle. It's, again, like totally typical, but not normal to not be able
Yeah.
to talk to the person you want to have sex with about the sex you want to have.
And I feel too like sometimes there's the idea that it'll be taken as an insult that what you were doing already wasn't good enough, which, let's just throw that out the window,
Yeah,
please. Like, open communication is not a attack on your skill set.
right.
So, also, like, never in my experience ever has anyone like come back with an attitude to me saying, do this, do that. Like, it's always been well received and then well executed because I said what to do. So, like, then everyone wins.
Right. So having an idea, and this is where actually seeking out a consult on like, what can we do? So we're experiencing pain, because one way to think about this is I'm experiencing pain. Another way to think about this is we're
It's a
experiencing
joint effort.
pain.
You're not sitting there idly just hurting. And if you are, come see me anyway. But
Yeah,
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 if you
and go ahead and go on your own. But like I'm thinking about doing a consult with someone. Like if your partner's open to coming and having this conversation. Like, that's what you train for. That's what you
Mhm.
do. You help
Mhm.
people have a better experience. And this is the wave of the future is that we're going to talk about all the things that we want to do and then do them. And
I
we can
find
talk
that
to
it
practitioners too.
Yeah, I find that it works really well too to have like a one-on-one conversation with like the client and myself first to kind of get down like what do you want? Like what is it that you're nervous about asking? And a lot of it is like I don't know if this is an okay thing to ask. Like is it okay to like this? Which is a whole other can of worms that we've had a good conversation about
We
before.
have. Like, yeah,
And
no more
so
pathologizing our
yeah.
wants.
Yeah. So I like having the conversation first. It's like, okay, what is it that we want to ask? And then how do we ask it? And then have a separate conversation. And it could be between the two of them or me and the client and their partner for like a
Yeah.
facilitated discussion to
Yep.
bring that up. And sometimes if it's something that's pretty out there, I'm a happy mediator to be like, no, that's real. Like she's not coming
Yeah.
up with something crazy or it's not illegal or whatever. But
This
yeah,
is just
just
one of the things I think people miss out on the idea. Like, you are many amazing things, but one of the things you are is a sexuality educator, and like sitting in that space of the mediated discussion, the facilitated discussion is one of the things I don't necessarily know that people think is available, is possible. And that might only be 10 minutes of an appointment, but
yeah,
wow, it can be a really powerful experience to have yourself validated and to have your partners hear hear how normal this is. And this is also why we wanted to record
yeah,
this episode. There's so much going on in our sex lives that we don't talk about, but we can talk about it.
yeah.
I don't want to leave without addressing something really, really important, which we've been focusing on, like the pregnant body, the birthing body, and the cis femme body that is experiencing pelvic pain, but boys have pain too. Do
Mhm.
do pelvic PTs treat men? And like, I know the answer, but say it out loud for everybody.
Yes, we do. When I was doing outpatient in New York, I think my caseload was 50-50 men and women,
Yeah.
um, and non-binary and trans, but 50-50 pretty much split.
Yeah.
Um, and so, yeah, whether that's, oh my gosh, post prostatectomy. So if you've had prostate cancer, you get that removed. That, goes around part of the urethra. A lot of men have incontinence after that. So work a lot on that. Any kind of like testicular pain as well. Men can get pelvic floor hypertonicity and cause testicular or penile pain. So working on that as well. And yeah, incontinence, fecal incontinence, the whole gamut of everything that goes on down there. Erectile dysfunction as well. If those muscles are and like men and women as well, like pain with arousal, right? So the pelvic floor muscles cover the erectile tissue. And so if
Yeah.
the erectile tissue is trying to fill with blood and the muscle is really, really tight, like cramped down on top of it, it's not going to have that room to expand. And that can be really painful. And so
Mm.
working on loosening those muscles so that then the erectile tissue can fill with blood like it's supposed to and not be painful. Men and women the same. But there's so many things to do.
There's so many things to do, and there's something to do about incontinence. There's fecal and urinary. So
Mm-hmm.
in other words, I don't actually have to pee when I do double unders. That's what I'm hearing
No,
you say. I
correct.
have never. I will totally own the fact that I have never addressed that fully. Like, I have
That one's
almost
usually
and then not quite nailed it, and then it's tough.
that
It's
one's
tough.
usually not a strength issue. It's usually a speed of contraction issue. So like if your coordination of the muscles isn't fast enough to close before the pressure of the jump comes down,
Yep.
you'll leak. You might be strong, but you might just not be fast enough with the pelvic floor contraction.
Yeah, I love that you're addressing all of these issues and that it's becoming normalized to ask for support, because I just used a lot of bleach on my CrossFit gym floor instead. That was pretty much my solution, was lots more bleach. Um,
So, what I think is really interesting about this conversation the whole time is that we've been talking, and Ariana's been describing how, yes, there are resolutions, there are approaches, strategies for dealing with all of these things. And we've just barely touched on some of the things that you might do, which means that there's a whole world of possible um, uh, shoot, I can't think of the word. Things to
Remediations.
do. Yeah,
Yeah.
remediations for these experiences that we have normalized, even though they're not normal.
Mm.
There's
And
one thing that sorry.
well, I was just going to say, I kind of want to have a whole other episode where we
Oh.
all the things we could do to make things better.
That is a great idea. I'm in.
Yeah, awesome.
There was one thing that it was brought up at work yesterday at the hospital because we had a prosthetic company come in to talk about amputees and limb fitting, and I asked them if they had like a sexual health consultant. And so I'm happy that now I'll be starting to work with them and be a resource for people with limb loss and limb differences. But just that whole arena of adaptive sex for people with mobility differences and the equipment required for that and the positioning. And there's so many things that we can do to make that so much more enjoyable and accessible and possible. And hopefully maybe a little more in the public eye too, because just because someone has a mobility deficit, a disability, or a neurologic condition or a spinal cord injury doesn't mean that they're not sexually active. And that's a population that's so underserved. And it's such a great window to just highlight that it's for everybody.
Sex is for everybody who wants it when they want it. Like that's what it's for.
Yep.
It's for pleasure. It's for joy. For
for fun.
connection. For fun. And I'm so glad to hear that, like, as a field, that your field is specializing and opening up to the ways we could potentially treat these. And some of them are like you already have the maps. We just need to get the people with the maps in
To the
touch with the
people
people
that
with
are
the
looking for the
problems.
maps. Yeah.
Yeah. So would you tell everyone where they can find out more and work with you potentially?
Yeah, if anybody's interested in working together, you can jump over to my website for booking a free call, and that's drarianacesare.wixsite.com. That's my whole name. If you just search in Google Dr. Ariana Cesare, a page will come up, and you can just click that. It's easier than remembering a whole website.
And the
And
link will
we'll
be
have the
in
links,
the
in the
notes
show
as
notes.
well. And you also have social media, and I love keeping this top of mind. So where should people follow you on socials?
On Instagram, it's Kegels and Kettlebells. So Kegels _and_ kettlebells. And then on TikTok, it's just Dr. Cesare, one word, all spelled out.
Love it. And really, Ariana, thank you so much for your brilliance. Thank you for being out doing this work. I'm
Thank you
really
so much.
just
Yes.
so thrilled. And
Yep.
absolutely, we will have you back to talk about this more. There's so much that we could have talked about. This is a big topic. I really encourage everyone to reach out. Consider taking your pelvic health seriously. And if you have a partner who you haven't been able to have the kind of connection with you want because of pain, maybe this is something you can work on together, is getting in contact with a professional who can help you have what you want. Thank you,
And
Ariana.
thank you guys so much. Yeah, women's health is everyone's health, and pregnancy affects 100% of the population.
Yes.
So.
Yeah, it really, really does.
You were either born or you are going to give birth at some point. I think everyone was born. So
yeah, we were all born. Here we are. Thank you, Ariana. I appreciate
Thank
you
you
so
so
much.
much, Ariana.
So good to see you guys.
We talk to you all the time. It is absolutely imperative to me that we get to hear from you as well.
Yes, please.
So we'd love to invite you to join us. Join Ken and I. We're holding monthly Ask Me Anythings. You can show up, bring your questions from podcast episodes, from your relationships, bring questions about non-monogamy, about individuation, about relationship skills. We would love to share space with you. We're hosting these AMAs free of charge for our podcast listeners. You are the Playing with Fire community, and it matters a ton to us that we connect with you directly. So
Oh, I would so love to hear your questions, and it'd be so awesome.
Yeah. Go to joliehamilton.com/AMA and you'll find a way to sign up real quick and get an invitation to join us in a small group where we're going to get together and talk about all things non-monogamy, individuation, and relationships.